Hi everyone, this is your Obesity and Bariatric Management lecture. We're going to talk about the patho behind obesity and related complications. We're going to talk about the different non-surgical and surgical interventions related to the bariatric client. We're going to develop a plan of care related to both non-surgical and surgical interventions related to the bariatric client, and we're going to evaluate ongoing health promotion and maintenance of the bariatric client. So I'm just going to go over some of the key points here. So what impacts our nutritional status? What affects how much we need? Maybe age, gender, if we have certain diseases, in times of infection, in times of stress, our requirements are going to be increased. And what actually affects how much we eat? Maybe we have certain eating behaviors, snacking patterns that might be due to certain emotional stability, times of stress. Certain economical factors can affect what we're able to afford to eat. Certain disease processes or being on certain drugs can certainly either make us hungry or lose our appetite. And cultural factors also affect what we eat, how much we eat. And talking about body mass index, it's a measure of nutritional status that doesn't depend on frame size. It indirectly estimates total fat stores within the body by the relationship of weight to height. So it is just as important to obtain an accurate height as it is to maintain an accurate weight. So there are different ways you can calculate BMI. You can do weight in kilograms divided by height in meters squared, or if you're doing it in pounds and inches, you can do weight in pounds divided by height in inches squared multiplied by 703. And an increased BMI has been a validated risk factor for developing cardiovascular disease. Also, we want to take into account where our fat is distributed on our body. We can talk about an apple-shaped versus pear-shaped body. That apple-shaped body talks about more central obesity, that fat around your belly, versus your pear-shaped, which might refer to more peripheral lower body obesity. We can measure waist circumference to see where our fat is distributed. And an increased waist circumference or central obesity is a strong predictor of coronary artery disease, stroke, diabetes, type 2, cancer, sleep apnea. And we can also get a waist circumference to hip ratio, which also predicts CAD. And the greater the ratio, the more risk you have of CAD. So moving on to patho, cytokines, which are high in obesity. Inflammation begins in the fat cells themselves, and fat cells are the first to be affected by the development of obesity. And as fat mass expands, inflammation increases, and that inflammation of the fat tissue can cause insulin resistance, which can then lead to things like diabetes. We also have anorexins in our body that we'll refer to as appetite suppressants. Leptin acts on the hypothalamus to control appetite. However, in some patients with obesity, that is actually elevated, which suggests leptin resistance. So leptin doesn't do its job. And leptin can stimulate the ANS, and can cause inflammation, causing ventricular hypertrophy, also increasing your risk for cardiovascular disease. Another way we control our appetite is through insulin, by allowing glucose to enter the cells. So when blood glucose goes up, your insulin goes up to try to control that blood sugar. When blood glucose goes down, insulin levels goes down. So this is kind of an ongoing cycle. Insulin resistance can lead to increased blood sugar, And in response to that increased blood sugar, your body secretes more insulin. And insulin shunts sugar to fat. So the more insulin you actually have increased fat storage, which can lead to obesity as well. And we also have orexins or appetite stimulants. An example of that is ghrelin, which we'll refer to as a hunger hormone that's secreted by a portion of the stomach. That's supposed to increase in times of fasting. And then after you eat, it's supposed to decrease. The causes or etiology of obesity involve multiple complex interrelationships of many environmental, genetic, and also behavioral factors. Starting with environmental, the media and certain advertisements have been around for high fat, high calorie, highly palatable foods that are convenient and expensive, often in portion sizes that are way more than recommendations. One of the most common causes of being overweight or obese is eating high fat and high cholesterol diets. Physical inactivity has also been identified as another cause of overweight and obesity. Some of the major barriers to maybe people trying to increase their physical activity might include maybe lack of time. They have a sedentary lifestyle that they've just become used to, or maybe they just have decreased mobility due to some type of illness. And also certain learned behaviors. Maybe in times of stress, we use eating as a coping mechanism. And we might just eat and not realize we're eating. We might have frequent snacking habits. We might eat late at night. And then sometimes learned behavior includes things like being told to clean your plate when we were little. That can influence our behavior and food preferences and influencing our weight in adulthood. Genetics certainly plays a factor in obesity. And genetic composition may predispose some people to obesity. There's also certain disorders that can affect weight gain and obesity. Prader-Willi syndrome is a neurodevelopmental genetic disorder that results from a hypothalamic pituitary dysfunction that prevents appetite control. If you have Cushing syndrome or Cushing disease, high levels of cortisol can lead to obesity, glucose intolerance, insulin resistance, hypothyroidism, slows your metabolism. That can cause weight gain. If you actually have injury to your hypothalamus, that's supposed to help control hunger. It's not going to regulate hunger properly. And in women, polycystic ovarian syndrome, caused by disruption with sex hormones, leading to weight gain and things like diabetes type 2. We also know that certain medications and drugs can impact weight as well. Being on corticosteroids, that can change lipid and carbohydrate metabolism to increase our appetite, which can lead to weight gain and obesity. Being on certain estrogens or progestins, NSAIDs can actually cause GI upset, which might actually decrease our appetite and lead to weight loss. And certainly being on antihypertensives, antidepressants, antiepileptics, and certain oral anti-diabetic agents can affect our weight as well. So what is metabolic syndrome? There are certain risk factors that increase our risk for cardiovascular disease and diabetes. You have to have at least 3 metabolic risk factors to be diagnosed with metabolic syndrome. One is a large waistline or waist circumference over 40 inches in men, and over 35 inches in women. We're having abdominal obesity, high triglycerides, or low HDLs, the good cholesterol. If you have hypertension, or you're on medicine to treat high blood pressure, and if you have a high fasting blood sugar, If you have at least 3 of those risk factors, you are at increased risk for metabolic syndrome. We all know that there's long-term complications that can happen with obesity, and one of our goals for obesity management is to prevent those long-term complications. Primarily, we see a lot of the cardiovascular and respiratory issues. Weight gain can also cause degeneration of the musculoskeletal system, especially the weight-bearing joints like the hips and knees, or osteoarthritis. And we also know that obese people have immunosuppression and are more susceptible to infections and other diseases and have decreased wound healing. So these are all the complications that can occur if we don't manage our weight. As part of our assessment, we need to get an accurate patient history, understanding their socioeconomic status, food intake and behavior or psychosocial patterns. What are their eating patterns? What are they eating? What are their portion sizes like? What are their attitudes towards food and eating? What is their 24-hour recall diet, where they remember their food intake and frequency in which foods are consumed? What's their cultural background like? What is their typical meal look like? What chronic diseases do they have, or medications they're on that can influence weight? Do they have a sedentary lifestyle? Do they exercise? Or do they have a family history of obesity? When we physically assess our patients, certainly we want to measure waist circumference and calculate the waist to hip ratio to measure central obesity. And another important component is skin assessment. Remembering to assess for reddened open areas, lifting those skin folds, looking under their breasts, looking in abdominal folds, especially to observe for candida or yeast infections. Just as important as the physical assessment is the psychosocial assessment. We need to obtain an accurate psychosocial history to determine the patient's circumstances and emotional factors that might prevent successful therapy. We need to ask the patient to determine his or her perception of current weight and weight reduction. We might ask questions such as, what does food mean to you? Do you want to lose weight? What prevents you from losing weight? What do you think will motivate you to lose weight? What are some of the benefits from losing weight? So we really have to ask their health beliefs about being overweight, because the patient will most likely make lifestyle changes and modifications if their beliefs are incorporated into the plan of care. Now moving on to what are some of our non-surgical interventions for weight loss, starting with diet programs. Short-term fasting programs have really not been successful in treating morbid obesity. It does not produce permanent benefits because most patients regain the weight that's lost by this method. Very low calorie diets, maybe even just 200 to 800 calories a day. Again, most patients regain the weight they lose. Nutritionally balanced diets generally provide about 1,200 calories a day with the even distribution of carbs, proteins, and fat. Unbalanced low energy diets, like your low carb diets, restrict one or more nutrients. And novelty diets or new diets like the Hollywood diet are often nutritionally inadequate. Again, with novelty diets, patients don't maintain the weight loss after stopping the diet. Along with changing eating habits, the major intervention to managing obesity is to increase the type and amount of daily exercise to burn calories. For most people, adding exercise to a nutrition intervention produces more weight loss than just dieting alone. And we need to teach patients that increasing and maintaining physical activity levels are important in maintaining weight loss. because many overweight or obese patients are so unfit that it may take several months of conditioning before they can exercise sufficiently to lose weight. So a minimal level workout should be developed so that consistency can be achieved. And our expected outcome is to maintain a lifetime of increased physical activity. Patients are likely to be less fatigued and discouraged with a low-intensity, short-duration program. And we want to encourage physically inactive patients to increase their activity by walking maybe 30 to 40 minutes at least 5 days a week. There are certain medications that people can take to promote weight loss. Some of them are anorectic drugs that suppress appetite, which in turn then decreases the amount of food they're eating, which leads to weight loss. Major concern with these drugs are cardiovascular complications if they use it for a long period of time. An example is Xenical or Orlistat. One of the side effects is GI symptoms unless you're adjusting your diet to make sure that your fat intake is less than 30% of your total food intake. And another one is Belviq or Lorcaserin. Phentermine topiramate is a combination of a weight loss drug plus an antileptic. You see the side effects there. And we might use other sympathomimetics that suppress the appetite center in the hypothalamus. An example is Apodexp. We also look at changing their mindset, changing their behavior. So behavioral management helps the patient change their daily eating habits to lose weight. And this ongoing process should produce a change in behavior. Self-monitoring techniques include keeping a record of food eaten or a food diary, exercise patterns, and emotional and situational factors. Reinforcement techniques are often used to self-reward the behavior change. Cognitive restructuring involves modifying negative beliefs by learning positive coping self-statements. And we usually involve counseling by healthcare professionals before, during, and after treatment. And there's often 12-step programs such as Overeaters Anonymous, especially for those that are compulsive eaters. So certain patients qualify for surgical intervention if they've had repeated failure of non-surgical interventions, if they have a high BMI, or if their weight is more than 100% above the ideal body weight. There's different types of surgical options. Gastric restrictive surgeries decrease the capacity of the stomach to limit the amount of food that can be eaten at one time. Examples are lap band surgeries and sleeve gastrectomies. Malabsorptive surgeries interfere with the absorption of food and nutrients from the GI tract. An example is biliopancreatic diversion, which isn't as common, so we won't really touch on that here. And gastric bypass, or Roux-en-Y, is a combination of a restrictive and malabsorptive surgery. And with any surgical approach, patients must agree to modify their lifestyle and follow strict protocols to lose weight and keep the weight off. And the goal of these bariatric surgeries is to prevent the long-term complications of obesity, such as diabetes, hypertension, depression, or sleep apnea. The adjustable gastric band, or the lap band, is reversible and is considered restrictive because you're using a device wrapped around the upper part of the stomach to form a ring, which has an access port left under the skin where the doctor or physician will inject saline through that port to make the band tighter if needed, and then they can remove some of the fluid to make it looser. So adding saline tightens the band to make the stomach smaller, and you can take the saline away if the ring's too tight. So you are needing close monitoring for band tightness and weight loss. Sleeve gastrectomy. you actually remove part of the stomach, usually the left side, where ghrelin, the hunger hormone, is produced. So the left side in this sleeve gastrectomy is almost removed entirely. So hunger is significantly reduced. It is irreversible because you're actually taking part of the stomach out. And it is restrictive, and it might have some malabsorptive effects as well. Gastric bypass, or root NY, is one of the most commonly performed bariatric procedures. It is a combination of restrictive and malabsorption. It is irreversible. You are essentially stapling the stomach into two sections. The top section becomes a small pouch that only really has about 30 mLs that serves as a new stomach. So the small size is restricting the amount of food intake. And it also provides a feeling of fullness and satisfaction with smaller portions of food. And the lower portion of the stomach no longer receives, stores, or mixes food. So that's the restrictive element. And the malabsorptive element is achieved by dividing the small intestine in a certain area. And once it's divided, the lower part of the intestine, or the jejunum, is pulled up directly to connect to the new stomach. And the other end of this divided intestine is sewn back at a specific point further down the small intestine. As a result, when you eat food, it then enters the new stomach, traveling into the jejunum, first bypassing the majority of the upper part of the intestine. So by bypassing the upper portion of the intestine, it decreases the amount of calories and nutrients that are absorbed into the body. So because it is restrictive and malabsorptive, you really need to teach these patients to maintain adequate hydration and increase their vitamin intake. So pre-op care is similar to that for any patient undergoing abdominal surgery, but obese patients are at increased surgical risks of especially pulmonary and thromboembolic complications, and some surgeons might even require limited weight loss before even getting the bariatric surgery to decrease these complications. We need to do a psychological assessment to screen for depression, substance abuse, or other mental health issues that could interfere with their success after the surgery. And we often provide education sessions, get them into a support group, and really the role of the nurse is to reinforce health teaching and educating these patients on what type of lifestyle modifications they might need to make after surgery. The priority nursing management is airway. Especially since obese patients often have short, thick, fat necks that might have compromised airways. So we might need an aggressive respiratory assessment and support. We can also think about pain management. All patients experience some degree of pain. They might need a PCA for the first day or so. We're going to encourage early ambulation. We're going to put on SCDs to prevent blood clots. We're going to do a thorough assessment of bowel sounds and incision, what the wound looks like, and getting accurate AccuChecks for those that are diabetic. Diet recommendations. We're really going to advance their diet slowly, starting with clear liquids in small cups, advancing to pureed foods, maybe even juice, soups, and milk. And we're going to recommend low-fat, low-carb, and high-protein, avoiding sweets, caffeine, carbonated beverages, and telling them to not drink with meals because that can cause nausea, vomiting, and discomfort. And they're really at high risk for nutritional deficiencies, especially for those that have gotten malabsorptive surgeries where you're not absorbing those nutrients. So talking about specific complications unique to bariatric surgeries, First is an anastomotic leak, where there's leaking of digestive juices and partially digested food through the unhealed bypass. That can be seen with bypass surgery and gastric sleeve surgeries. You might have tachycardia, back, shoulder, abdominal pain, nausea, vomiting, hypotension, oliguria. And for this, we really need to get them back to the OR to drain the infection, repair the leak, and maybe even make a new anastomosis. Dumping syndrome, we really see that with bypass surgeries, caused by eating high sugar, high fat foods that rapidly enter from the new stomach into the small intestines. Symptoms can be seen within approximately half an hour after eating those high sugar, high fats. It can cause vertigo, syncope, tachycardia, sweating, palpitations, nausea, vomiting, nausea, diarrhea, abdominal cramping. So we really need to review dietary intake with these patients and make appropriate changes. And specifically with lap bands, the band can slip, creating a larger pouch. Patients might have epigastric pain, dysphagia, dyspepsia, nausea, vomiting. So if the band slips, we need to take the food out from the band and or remove the band itself. Sometimes the band might erode all the way through the stomach wall. Patients might have pain and GI bleeding. In that case, we completely need to remove the band. So how do we prevent some of these post-op complications? Airway management. You might place the patient in a semi-Fowler's position, or even use BiPAP or CPAP at night to improve breathing, decreasing their risk for sleep apnea or other pulmonary complications like pneumonia and atelectasis. We might monitor O2 sats, provide oxygen as prescribed. For DVT prevention, putting on those SCDs, administering prophylactic anticoagulant therapy to prevent complications such as PE. Skin care, observing those skin areas and folds for redness, excoriation, breakdown, and treating the problems early. Infection prevention, maybe applying an abdominal binder to prevent wound dehiscence for open surgical procedures, getting those catheters out post-op day 1 to prevent UTIs. And early ambulation is key as well to prevent DVTs and PEs. So lots of components to discharge teaching after bariatric surgery regarding nutrition, how to advance their diet, making sure they get nutrition supplements, guidelines for hydration, not drinking with meals to prevent that nausea, vomiting, and upset. They might be on analgesics, they might be on antiemetics if needed. Proper wound care for open or laparoscopic wounds, covering them, what their activity level is. They might have certain restrictions. We want to tell them to avoid lifting, slowly returning to driving, slowly returning to work. What signs and symptoms they need to report: fever, excessive nausea, vomiting, epigastric pain, back pain, shoulder pain. If their wound shows any sign of redness, swelling, they have chest pain, difficulty breathing. Do they have proper follow-up care with healthcare providers or clinics, support groups, community resources? They might need counseling. And continuing education with nutrition and exercise classes, maybe dietitian visits. So what are our goals for these bariatric surgery patients? We're going to see a lot of cardiovascular benefits and resolution of some of these complications. For cardiovascular, hypertension can often resolve, diabetes can often resolve, and they might no longer need anti-diabetic medication. Their blood sugar is going to be back to normal. Respiratory benefits, maybe decreasing sleep apnea. Musculoskeletal benefits, because all that weight isn't going to be stressing their joints. And urinary continence. Maybe because less weight is placed on the bladder, it can lead to a decrease in things like stress incontinence that can resolve after bariatric surgery. So what is our long-term goal of bariatric management? Again, decreasing those comorbidities such as hypertension, diabetes, sleep apnea. It is a chronic lifelong problem. Diets, drug therapy, exercise, and behavior modification can produce short-term weight losses with reasonable safety, but most patients who do lose weight often regain it. So the treatment of obesity should really focus on the long-term reduction of health risks and medical problems associated with obesity that can improve quality of life. And in order to do that, we as interdisciplinary team members really need to provide a non-judgmental, supportive atmosphere to encourage them to increase physical activity, change their diet, and we also need to take into account their psychological issues and concerns. So that is obesity in a nutshell. Use the discussion board if you have any additional questions, utilizing your student handouts, and I hope you all have a good evening.